Hatvet PHARMA welcomes you to the ocean of practical knowledge about small animal practice, that is, Hatvet's YouTube channel. We are thankful to our honorable speaker and session moderators for sharing their valuable time and knowledge with us.
So, my dear friends, welcome to our webinar. And this webinar again is so special that this webinar deals with a simplified cardiology and ECG for field vets. So, as we all know, cardiology is so vast, the cardiac physiology, studying the different functions of the heart, the physiological episodes happening. All those, when going into detail, it will take a very, very long time. So, I would like to concise all the portions and simplify it for our field vets. Thank you and welcome to all to this webinar. Let us first of all see the canine heart. This is just to refresh the ideas and the knowledge you have. The canine heart, as in the human being, we have the atrium on the top, atrium on the dorsal aspect, on the anterior aspect, and posteriorly we have the ventricles, the right and the left atrium, then the aortic arch, aorta starting from the left ventricle, the pulmonary artery starting from the right ventricle. All those things we know, the coronal vessels. So this is the real picture of this anatomical peculiarities. You can see the trachea here. This is the aorta. You can see the left subclavian artery, the right subclavian artery. This is aorta, and here you can see the left atrium, the left ventricle, the right ventricle, and the right atrium. Everything you can see. This again cut open, and this is the left ventricle. This is left ventricular wall. You can see the chordae tendineae. You can see the mitral valve, the leaf of the mitral valve. You can see the muscular pectinate. You can see the pulmonary valve. You can see the pulmonary valve which opens into the left atrium. You can see the pulmonary artery here. The right ventricular wall. You can see the difference between the thickness of the left ventricular wall and the right ventricular wall. Here also see it is clear here. The right ventricular wall thickness, the left ventricular wall thickness. So the left ventricle is having more action. And normal cardiovascular system. We can say the circulation, according to the William Harvey's theory of circulation, the circulation starts at the right ventricle. And during the systole, blood is pumped into the aorta and it goes to systemic circulation. After distributing blood everywhere, it goes to the capillaries and then turns to the venous capillaries, then turns into the venules, the veins, and the systemic veins open into the vena cava, and both the vena cava, the superior, that is anterior vena cava or the cranial vena cava as well as the posterior vena cava, both will enter the right atrium or drain into the right atrium. From the right atrium, during a diastole, blood enters the right ventricle, and after that, during a systole, the valve will close and the blood will be pumped out through the pulmonary artery and reaches the lung for the pulmonary functional circulation. And from there, the oxygenated blood will be carried through the pulmonary vein into the left atrium. And from the left atrium, during a diastole, it enters the left ventricle. And during a systole, the mitral valve will be closed. The valve here, the ventricular valve will be closed here, and during the systolic blood will be again pumped into the aorta, and the circulation is continued. So this is William Harvey's theory of circulation. We know it very well. This is just an illustration of the heart, the anatomy of the heart. You can see this is the left ventricle, the right ventricle. This is the interventricular septum, the left ventricular wall, the right ventricular wall. This is the base, and this is the apex. You can see from the left ventricle starts the aorta, In aorta, you can see the semilunar valve. Semilunar valve always, the semilunar valves open into the aorta. See, the semilunar valve is opening into the aorta, and here on the right ventricle, you have the pulmonary artery. There also semilunar valve is there. It again opens into the aorta, in the pulmonary artery. And you can see the right atrium, the left atrium. Into the left atrium, the pulmonary veins are draining in, and the cranial and the caudal vena cava are draining into the right atrium. And you can see the interatrial septum, the atrial wall. You can see the atrial wall, and demarcating the upper and the lower chambers. You can see the left upper and the lower chambers, that is the atrium and the ventricle, are demarcated by the mitral valve, which has two strong leaves. And on the right side, demarcation between the right atrium and the right ventricle is a tricuspid valve. You can see the tricuspid valve here. All those things you know very well. This is another just illustration. You can see the tricuspid valve here. Because the mitral valve is so strong, because you can imagine circulation to giraffe. See, liters and liters of blood should be pumped into the head of the giraffe. So, how much strong the left ventricle of the giraffe will be. So, also the camel with a long head, long neck. Blood has to be pumped into the head through the neck, through the carotid artery. And so, how much of pressure the left ventricle has to exert to pump that much of blood into the head, which is always held very high. So, that much strong is the left ventricle. And some animals, like the ox, the buffalo, the camel, etc., we have bones inside the mitral valve to make it more stronger. Otherwise, during a systole, this mitral valve may break up. In order to avoid the rupture, the nature has given this. And now we will have to go to the conduction system of the heart. See, the heart itself, we can say as a battery. And the heart itself has a point where some potential, electrical potential is arising. That point is situated somewhere near the basilar areas of the right atrium. We can call it as a, we can say it as a sinoatrial node or the SA node. So, SA node is the point from where electrical impulses arise in the heart. So, from the SA node, electrical impulses will be traversing through the myofibrils and the conduction pathways of both the atrium, that is the left and the right atrium. And after that, this electrical potential should be reaching the AV node. AV node is situated at the, is otherwise known as junctional node. It is situated at the atrioventricular junction. And as well, see there are certain pathways by which, electrical pathways by which this polarity or this electrical potential is being transversed through. And this traverses the atrial wall. And after that, while it is polarizing the whole atrial wall, it becomes a little weak. And after that, it reaches the AV node. And it is passed through the AV node. We can say AV node can be used as a transformer by which the weak electrical impulses or the remnant impulses are being absorbed by the AV node, and through the AV node it runs, and we can say it is boosted. And after boosting, this will be transmitted into neurofibrils known as bundle of His. The bundle of His is traversing through the interventricular septum downwards or towards the apex, and then it eventually divides into two. The right side, the right branch, which is traversing or supplying the whole right ventricular wall, and the left branch, which is supplying the whole left ventricular wall. And so the neurofibril which is supplying the right ventricular wall, we call it as right bundle branch, and the neurofibril which is supplying the left whole wall, we call it as the left bundle branch. See, the left ventricle is little big and it has not much demarcated but slightly demarcated two chambers, the anterior and the posterior parts. And both these parts are supplied by again by two branches of the left bundle branch. So the left bundle branch again is divided into the anterior fascicle and the posterior fascicle. The anterior fascicle supplies the anterior areas, or in the animal it supplies the ventral areas of the left ventricle, and the posterior fascicle supplies the posterior areas of the upper or the dorsal areas of the left ventricle. And all these, the right bundle branch, the left fascicle, right fascicle, etc., everything will be immersed or distributed into the right and the left ventricle through certain neurofibrils known as Purkinje fibers. And so generally this is the conduction system of the heart. The same thing illustration you can see the sinoatrial node. From the sinoatrial node, we can see the impulses, electrical impulses are arising, supplying the whole right atrium and also the left atrium. After that, it reaches the sino-AV node, the atrioventricular node. From the AV node, it reaches through the gains entry through the bundle of His. Bundle of His then divides into two, the left and right bundle branches. The right bundle branch then supplies the right ventricular wall, and the left bundle branch then again divides into two. The left and the right fascicles supplies the left ventricular wall. So we can say the heart, we can consider it as a small battery because the heart gives up certain small electrical impulses, which is very small, but actually, as this figure says, it is not strong enough to light a bulb. So each battery has a negative electrode, that is a cathode, and a positive electrode, which is an anode. And so the cathode and the anode can be connected to a bulb, and sometimes if as we hallucinate, we can glow a bulb, but a bulb will not glow in that small electrical impulse. Just to illustrate that as a battery, the heart has a negative electrode, that is a cathode, and positive electrode, that is an anode. So suppose we are not using a bulb, we are using a micro galvanometer. A galvanometer itself will detect the minute electrical impulses. And if micro galvanometer is used, like ECG machine is a galvanometer, and these galvanometers, both the terminals are connected to the heart, you can see that there is deflections in the galvanometer. So this deflection is drawn on a running paper, and this is ECG. Got it? Simply that is ECG. But we cannot open up the heart and put the electrodes and then connect it to the, see, this cannot be done. So we make use of the limbs and the chest where the electrical impulses are traversed. And from these areas, we take out the electrical impulses and pass it to this galvanometer. And the galvanometer itself is modified. It is modified to an ECG machine. So we can see, I said that it draws a certain pattern. See, you can see a cell, a battery, a cell. The cell produces direct current, but a dynamo produces alternating current. Here also an alternating current is formed. That is why the deflections in the ECG paper or the running paper will be having too much of curves and ups and downs. So one single up and down comprises of a lub and a dub. A lub and a dub, when drawn on a piece of paper, is known as a sinus complex. So the sinus complex comprises of the P wave, Q wave, R wave, S wave, and T wave. And we have the PR interval, we have the P wave amplitude, we have the R wave amplitude, R wave width, ST interval, the T wave amplitude, etc. All those things has to be studied. So now we can see the P wave here. The green one is a P wave. The yellow one is a Q wave. The red one is the R wave. The violet one is the S wave, and the blue one is a T wave. In between the P and Q, you can see the PR interval, and in between the S and the T, you can see the ST interval, that is ST segment, and you can see the QT interval also. So these are significant things. So these are the attributes which we have to check when we are looking a sinus complex, like the P wave. See, the P wave is a P wave. The P wave width, the P wave amplitude, then the PR interval, that is from the start of the P to the start of the Q, that is a PR interval. Then the Q wave, this is a P wave is a positive wave, you can see here. It's a positive wave, Q wave is a negative wave, R wave is a positive wave, S wave is a negative wave, and here T wave is a positive wave. So P is a positive wave, after that PR interval is there, then a Q wave, it's a negative wave. Then you have a big R wave, the R wave amplitude, R wave width. Then after that there is a S wave, which is negative in nature. And after you have an ST segment, and then you have a T wave. There you have the T wave width, T wave amplitude, etc. So all these things, all these attributes should have to be studied when we are examining a strip of ECG. So these are again. Now let us study how these waves are formed. Like the P wave. As I said that electrical impulses are produced from the sinoatrial node. During the sinoatrial node is producing an electrical impulse, it will traverse and polarizes the whole right atrium, atrial wall, as well as the left atrium. And during this time, a positive wave arises, that is the P wave. So you can imagine, first to polarize is the right atrium, and second to polarize is the left atrium. So in a P wave, the uphill always denotes the right atrium and the downhill denotes the left atrium. Got it? That is very important. And whenever there is enlargement of the right atrium, there will be increase in the peak of the P wave. And when there is enlargement of the left atrium, there will be increase in the width, because there will be increase in the length of the downhill, and there will be increase in the width of the P wave. So increase in the amplitude of P wave shows that it is right atrial enlargement, and increase in the width of the P wave shows that there is left atrial enlargement. In conjoined left and right atrial, bilateral enlargement, there will be increase in peak as well as increase in width. Then the PR interval. Coming to the PR interval. After the P, there is a Q, and then next is the R. See why this PR interval happens. After traversing, after giving off the electrical impulse by the SA node, this electrical impulse completely polarizes, or we can say atrial depolarization. Atrial depolarization. So atrial depolarization occurs, and after that, the electrical potential will become feeble, somewhat feeble in nature, and by that time it will be collected into the atrioventricular node, that is the AV node situated at the junction. And through this AV node, it will be passed on. While through the AV node is passing on, it will be slightly boosted. This electrical impulse, which is very weak, becomes little boosted. And while it is passing through the AV node, there is a small delay. While there is a delay, this delay is there. There are no deflections, nothing at all, and then we will have a flat wave. This flat wave is the PR interval. This is the PR interval. You can see it. It's a PR interval. It's a flat wave. And after that, it suddenly traverses, it reaches the Purkinje fibers, sorry, it reaches a bundle of his, and suddenly it jumps into the bundle of his, and quickly it traverses towards the apex through the bundle of his. By this time, the basilar areas of the interventricular septum may not be polarized, and during this time, some amount of electrical impulses will go back. That's it. See, some impulses may go back and polarize the basilar areas of the interventricular septum. So that is a Q wave. What happens here is that whenever the electrical impulse is moving from the base towards the apex, produces a positive wave, and whenever it is reversing its movement, it is moving from the apex towards the base, it produces a negative deflection. That is what is seen in the ECG. And here also, the basilar portions of the interventricular septum will be repolarized, will be depolarized slowly, and will have a slight delay. And this depolarization of the interventricular septum, when occurs, for this electrical impulse should traverse from the apex towards the base, that is from here to this area. So while it is traversing from the apex towards the base, it produces a slight negative deflection. We term it as a Q wave. So Q wave denotes a remnant or basilar atrial septal depolarization. I think you got it. Basilar ventricular septal depolarization. And after the basilar radius of the ventricular septum is depolarized, again the impulse is traversing through the bundle of his downwards towards the apex, then going through both the bundle branches. Then ultimately it is completely polarizing the ventricular, both the ventricular wall. During when it is polarizing both the ventricular walls, the ventricular walls will be having a heavy contraction. It is known as a systole. And this systole is denoted here as a very large positive wave. That is the R wave. So as when we see the P wave, the uphill indicates the right atrium and the downhill indicates the left atrium. Here also in the ventricles, the uphill of the R wave indicates the right ventricle and the downhill indicates the left ventricle. So when there is enlargement of the right ventricle, naturally there will be increase in the peak, increase in the amplitude of the R wave. And when there is down peak or the downhill, when there is increase in the size of the left ventricle, naturally the downhill will becoming more lengthier, and so there will be more width of the left ventricle, more width of the R wave. So increase in the amplitude of the R wave indicates right ventricular enlargement, and increase in width of the R wave indicates left ventricular enlargement. If there is biventricular enlargement, both amplitude and the width increases. Okay, I think you got it. Then coming to the S wave. S wave again is a negative wave. Why? Because after completely polarizing both the ventricles, some basilar areas will be remaining. To polarize the basilar areas, some small amounts of electrical impulses will be moving from the apex towards the base for depolarizing the basilar areas. So during this movement from the apex towards the base, there will be a negative deflection, that is a S wave. So S wave indicates remnant ventricular basilar depolarization. Remnant ventricular basilar depolarization. So that is S wave. So whenever there is hypertrophy of both the ventricles, there will be increase in depth of the S wave. Then the T wave. T wave actually indicates the complete repolarization. Means polarity has already been happened, and the ventricle has undergone a big contraction, and after that, some remnant electrical potentials will be passing hither and thither, will be producing small deflections, and always a T wave is formed, that is ventricular ventricular repolarization of the remnant electrical potentials. And so during this time, there will be either a small peak, a positive one, or sometimes a negative one. Mostly in human beings, it will be positive only, but in the dog, it can be positive or it can be negative. Both are normal. So that is regarding the T wave. And T wave has a high significance because when there is increased potassium level of the blood, the T wave amplitude increases. That we are coming. And now we are looking the ECG. The ECG machine actually is looking the body or looking the heart from different directions. We have the limb lead system. Now we have the unipolar limb lead system, that is L1, L2, L3, and the augmented limb lead systems, the AVR, AVL, and AVF. These are the 6 basic leads which we have to study. What is a lead? It is just a combination of 2 electrodes. Combination of two electrodes. So lead 1, it's a unipolar limb lead system. In this unipolar limb lead system, you can see the L1 is formed as a combination between the right and the left forelimb, where right forelimb is the negative electrode and the left forelimb is the positive electrode. And the galvanometer is connected to both these limbs. We get, when you take the ECG, you get the L1. So through L1, actually this galvanometer is looking transversely through the heart. Heart is slightly towards the left side. And this is almost transversely to the heart. Coming to the L2, in the unipolar limb lead system, we have the L2. L2 is formed as a combination of the right forelimb as the negative electrode and the left hind limb as a positive electrode. See, in all the ECG, the right limb is always kept, the right hind limb is always kept as the earth. See, in L1 also you can see the right hind limb is the earth. Only other 3 limbs we are using. And this is L2 is a combination between the right forelimb as a negative electron and the left forelimb, left hind limb as the positive electron. That is L2. Now this heart is looking from the base to the towards the apex, almost parallel to the long axis of the heart. That is why it is said that in unipolar limb lead system, L2 is the most important one, especially for beginners. Just take L2 only and study. Just take L2 only and study. That's all. That is regarding L2. Then L2 is very important. L3 is almost also like L2, almost similar to L2 because the galvanometer is looking the heart almost through the long axis of the heart. Again, L3 is also almost similar to the L2, where it is a combination unipolar limb lead system where the combination is between the left arm and the left arm and the left hind limb, left forelimb and the left hind limb, where the left forelimb is a negative electrode and the left hind limb is a positive electrode and the right hind limb is the earth. So that were the L1, L2 and L3 were the unipolar limb lead systems. And coming to the augmented limb, L3 is coming to the L3, and now the coming to the augmented limb lead systems. In augmented limb lead systems, we are augmenting the negative electrode. So the negative electrode is taken as a combination of 2 limbs. In augmented vertex right, that is AVR, it is an augmented limb lead. In this augmented right limb lead, you can see that the ECG machine is looking from the left side towards the right side. From the left side towards the right side, and from the apex to the base against the long axis of the heart. It is just to the long axis but reverse from the apex towards the base. So all the positive deflections which you see in a normal ECG will be negative. P will be negative, Q will be positive, R will be negative, all those things will happen. I'll show you. So here augmentation is done by the combination of the negative electrode. See, the combination is done by left forelimb and left hind limb as the negative electrode, and the positive electrode is the right forelimb. So that is AVR. And coming to the AVL, in AVL is just the reverse. It is looking the heart from the base of the heart towards the apex of the heart towards the base, from the right side towards the left side. That is AVL, augmented vertex left. Here, the negative electrode is a combination of the right forelimb and the left hind limb. And the positive electrode is the left forelimb. So that is AVL, augmented lead. So what is a lead and what is an electrode? Electrode is just what we are fixing into the skin, and lead means it is a combination of electrodes. Those you should not forget this difference. Then coming to the AVF, augmented vertex front, and in this you can see that the augmentation is done between the combination, negative electrode is a combination of both the forelimbs, and the positive electrode is the left hind limb, and the right hind limb is the earth only. Here also in AVF, the ECG is looking the heart from the base towards the apex, almost similar to the L2 in unipolar limb lead system. So you can see that this AVF is also very important as like the L2. So in our 6 lead system, in the unipolar system, we have the L2, and the augmented system, we have the AVF. So L2 and AVF are the most important one. Among these two, L2 is the most important one. Basically, anesthesiologists, etc., they will look only this L2, because that is all needed for normal studies of the heart. These are these are positive waves. You can see the L2. L2 this is looking the heart through the almost the long axis. The AVF also long axis. You can see the positive waves. L3 also you can see the positive wave. But look the AVR. AVRs you can see the P wave, PQ, R wave, S wave, etc. Everything are negative waves. So sometimes ectopic focus occurs when there is myocarditis. The focus of myocarditis itself can act as the electrical potential generating focuses or foci, like the SA node. And that focus of myocarditis itself will act as a source of electrical potential. And so an ectopic beat in between can occur. And this ectopic beat has no much similarities, but has some similarities of a normal sinus complex, but will be wide, bizarre, and abnormal. That is known as an ectopic focus. This ectopic focus can be seen anywhere. It can be seen in the ventricles. As when it is seen in the ventricles, we can say it is a VPC, that is a ventricular premature complex. And this focus of myocarditis is seen on the junctional node, or in the atrioventricular node, we can say it is JPC, the junctional premature complex. And if it is seen on the atrial wall, we can say it is supraventricular premature complex. So all these things are generally used in detailed cardiology. Let us study something about the ECG paper. ECG paper is nothing. It is just a graph paper what we study during our primary classes. 1 centimeter square is there, containing 1 centimeter square is there, and inside 1 centimeter square we can see 100 small boxes. That means a large box will contain 100 small boxes. So this large box, this is 1 centimeter square, large box. And it is divided into 4, 25 small boxes each. 25 plus 25 plus 25 plus 25 makes 100 small box. So one big box is 1 centimeter square and one small box is 0.1 centimeter square or 1 millimeter square. That is 0.1 centimeter square. So in a graph paper, we have the y-axis as well as the x-axis. X-axis is always horizontal and the y-axis is always vertical. And so this paper is moving. You know the paper is moving. So the x-axis is always moving. There is no change in the y-axis. The x-axis is moving. And so this moving has a specific speed, the paper speed. Generally, we put, in all the ECG machines, the paper speed is put as 25 millimeter per second. So that means in 1 second, 25 small boxes will go. One small box is equivalent to 1 millimeter. So in 1 second, 25 small boxes, that is 2.5 centimeters will go. That is 25 millimeters will go. And sometimes if you want more clarity, we can increase the speed to 50 millimeter per second speed. So generally when you see an ECG paper, the ECG paper where the speed is not written, it is only 25 millimeter per second speed. And there is y-axis. The y-axis indicates the amplitude of the wave. While coming to the amplitude, 10 millimeters make 1 centimeter. So 1 millimeter is equivalent to 0.1 milliwatt and 1 centimeter is equivalent to 1 milliwatt. 1 centimeter is equivalent to 1 milliwatt. So one small box or 1.1 millimeter is equivalent to 0.1 milliwatt. Suppose a wave has 9 small boxes height. What will be the amplitude? It is 0.9 milliwatt. So it is easy. So another thing is that the paper is moving in a speed and 25 millimeter per second. Suppose we take 25 millimeter per second. And in 1 second, 25 small boxes are passing through. So how much of time will it take for one small box to pass through? That 1 milliwatt or so 1 millimeter to pass through. One small box to pass through. 1 divided by 24, which is 0.04 seconds. 0.04 seconds. It's very easy. So one small box, if the x-axis is 0.04 seconds, in the y-axis it is 0.1 milliwatt. Got it? And if the paper speed is 50 millimeter per second, again the arithmetic changes. There is no change in the amplitude, but the speed is changing. It is 1 divided by 50, which is 0.02. So if the paper speed is 50, one small box takes 0.02 seconds to pass through. Got it? You should not forget this. These are basic things. See, coming to these are things which either we have to by heart or we have to make a chart and paste it in inside our OP room. The heart rate of adult puppy, etc. is written, cat is written. The P-wave duration, that is x-axis. The P-wave duration in giant breeds it should be below 0.05 seconds. One small box is 0.04 seconds. And other breeds, in small breeds, it is below 0.04 seconds. And P-wave amplitude, it is always expressed in milliwatt. P-wave amplitude is below normally it should be below 0.4 milliwatt. In the cat should be below 0.2 milliwatt. And PR interval, it is an x-axis. Normally it should be 0.06 to 0.13 seconds. And the dog. Okay, the QRS duration. In giant breeds, it should be below 0.06 seconds. It is an x-axis. And in other breeds, it should be below 0.05 seconds. R-wave amplitude, it is expressed in milliwatt. In giant breeds, it is below 2.5 milliwatt. And in other breeds, it should be below 2 milliwatt. And ST segment, T-wave, QT interval, everything is written. So we can study all these things. The limb standard, normally the right forelimb is colored as red, the left forelimb colored as yellow, the right hind limb as green, and right hind limb as, that is, the earth is always black. This is the ECG machine what I am having. This is the BPL Cardiology 108T is what I am having. It's a single channel ECG machine. In this ECG machine, we have, this is my on machine. We have too many buttons. This is the on-off machine. It's a filter. And this is paper speed. and this is a sensitivity clip button, and this is the mod, and this is to change the leads, and this is the on off switch, pause and not pause, open switch, that is all. So this has to be operated and shown how it is taken, and these are the cables or electrodes which can be attached. You see, and for the human beings we are using vacuum cups or which comes in contact with the skin with gel, but this is not actually useful. We can use with sufficient quantity of gel, it can be used and taped to the limb, but it is better to use crocodile clips. I am using crocodile clips only. This, especially crocodile clips can be, it is available online, or if you go to purchase the crocodile clip which is used in electrical industry, it is very strong. It may injure or uh, give pain to the animal. It should be very smooth. This ECG paper, charring paper and ink paper are available. We can, ink paper is much more, little bit more expensive, or not expensive, more costly. Okay, then we can buy it. Then depends upon according to the machine also. The charring paper means we will have to. It has a powdery coating, and the ECG machine, when it is put on, the stillet is there. The stillet is actually deflecting, and the stillet will get heated, and it will rub onto the charring paper, producing charring effect and producing lines, black lines. So we'll have to put it on for 10 seconds, and then while this it is getting heated, then we can put it on after clipping the electrodes. This is ECG paper, and this is the positioning. Now the patient should be kept on a table with a rubber mat or cloth mat, and the man who is a technician who is holding the animal actually should cover their arm with gloves, rubber gloves. Otherwise, conduction can occur. So the anterior limb electrodes can be clipped to the areas of the posterior elbow joint, and onto the anterior stifle joint also the limb electrodes, hind limb electrodes can be clipped, and it should not move. So this is now you see the position. He has put on the glove, and with this we can take the ECG very easily. Again, you can see this. See this. And now sometimes in cats, in pugs, etc., in small breeds, sometimes it may, if you forcefully make the pug lie down, sometimes cardiac arrest can occur. And so the pug, you can take the ECG in standing position itself. So also in the cat, ECG can be taken in the standing position itself. So we have some chamber size disorders like the dilated cardiomyopathy. You can see this is the normal heart, where you can see the left ventricle, the normal left ventricle. See, this is a dilated heart. You can see the right dilated ventricle and the left dilated ventricle. You can see the thickness, the thin ventricular wall. That is dilated cardiomyopathy. And this is normal heart. You can compare with the hypertrophic cardiomyopathy. You can see the hypertrophied left ventricular wall. This is LVH, left ventricular hypertrophy. And left ventricular hypertrophy can occur due to mitral valve defect. Right ventricular hypertrophy can occur due to defect in the tricuspid valve. See, even left ventricular hypertrophy itself or right ventricular hypertrophy itself can occur in two different forms. Sometimes the hypertrophy is growing into the lumen of the ventricle, into the chamber of the ventricle, and so the lumen size or the filling chamber size of the ventricle will be decreased, and such a hypertrophy is known as a concentric hypertrophy. And sometimes this chamber size is not affected, or the chamber filling area is not affected, it is growing outside only. This is known as an eccentric hypertrophy. So both are dangerous. Eccentric hypertrophy means in radiography we can see the enlarged heart, but if it is a concentrated ventricular hypertrophy, we may not be able to detect in the radiograph because the hypertrophy is too inside, and we cannot detect it in radiography. What we have to do, cardiac ultrasound to find it out. So both are dangerous. If it is concentric hypertrophy, the filling chamber is obliterated, and so the stroke volume will be less. And so the in eccentric hypertrophy, it will be pushing off other areas, like it will be pushing the lungs, it will be pushing the trachea or curving or kinking the trachea. So cough occurs. So you can see a normal heart, an eccentric hypertrophy, concentric hypertrophy, all those things. See another thing. So we have studied about dilated cardiomyopathy, hypertrophic cardiomyopathy. Now the third one is restrictive cardiomyopathy. In restrictive cardiomyopathy, due to chronic inflammation of the endocardium, there will be scar formation in the endocardium. The endocardium, the elasticity of the endocardium will be lost, and so it cannot relax that much. So there is a restriction of relaxation. That is known as a restrictive cardiomyopathy. This also is very serious, restrictive cardiomyopathy. So we have the normal heart, dilated cardiomyopathy, we have the hypertrophic cardiomyopathy, and we have the restrictive cardiomyopathy. These are the chamber size disorders. In the dog. Now we will go to some ECGs. This is a normal sinus rhythm. You can see the RR interval is normal. You can see the P wave, S wave, R wave, Q wave, and T wave. Everything can be seen. Everything is normal. See, it's a normal sinus rhythm. And when there is sinus tachycardia, you can see there is increase in heart rate. So the RR interval will be becoming very less. Naturally, normally in feline ECGs, they'll be having short sinus complexes. Then sinus bradycardia, the RR interval will be very abnormally long. It occurs in increased intracranial pressure, hypothyroidism, hypothermia, hyperkalemia, hypoglycemia, etc. These are all proven ones. Sinus bradycardia in the cat. See, I already mentioned that the sinus complexes of the cat will be generally or normally very short. This sinus bradycardia, you can see the long RR interval in this cat. And how will you calculate the heart rate in eurythmia? If it is having a normal rhythmic heart rate, how can we calculate? If the paper is running in 25 millimeter speed, in 25 millimeters, that is in 25 millimeters in 1 second. So in 1 minute, 25 into 60, 1500 small boxes will be passed off. Heart rate in BPM, beats per minute, is equal to 1500 divided by the RR interval. Suppose the RR interval is 10. Suppose the RR interval is 10. 10 small boxes. What is the HR? What is the heart rate in 25 millimeter speed? 1500 divided by 10, that is 150. It is having a normal heart rate. So we can say that. So once again, how will you calculate the HR in eurythmia? It is in 25 millimeters per second, 25 millimeters per second speed. In 1 second, 25 small boxes will be passing on. So in 1 minute, that is 60 seconds, 25 into 60, 1500 small boxes will be passing on. And the HR in beats per minute is 1500 divided by the RR interval. How many number of small boxes are there between the R, both consecutive RR interval? If it is in 50 millimeter per second speed, everything doubles. In 50 millimeter per second, 50 small boxes in 1 second. So in 1 minute, 50 into 60, 3000 small boxes. So HR in beats per minute is equal to 3000 divided by the RR interval. So the same animal which is having the RR interval 10, if it is run in 50 millimeter per second speed, the RR interval will be naturally 20. So 3000 divided by 20 is 150. The same HR will come. See the normal ECG, calculate the HR. This is just an arithmetic for the our students. Yes, this is having a somewhat little bradycardia. We can calculate how many small boxes. So as you can see, 1, 2, how many small boxes are there? It should be eurythmic. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So this is if it is having the RR interval of 16. So when if the paper speed is not mentioned, it is 25 millimeter per second speed second only. So 1500 divided by 16 gives the HR. 1500 divided by 16. See, it is 93.75. Suppose it is 94. We can say it is normal. Normal only. It is normal only. Looks like bradycardia, but we have to calculate scientifically. Then only we can say it is abnormal. See, if it is arrhythmia, see, I have mentioned about how it is calculated in eurythmia. But if it is arrhythmia, in 25 millimeters, for example, in 25 millimeters per second speed, in 1 second it passes 25 millimeters. So in 6 seconds it passes 25 into 6, 150 millimeters, that is 15 centimeters. Count how many ROs are there in 15 centimeters. It's so simple. Multiple it by 10 to get the HR in 1 minute. See, it's so simple. So that everything doubles in 50 millimeter per second speed. Then coming to sinus arrhythmia, you can see the different RR intervals. This is sinus arrhythmia. Again, you can see in this lower one also. Then ventricular premature complex, I told that BPC arises when there is a focus of myocarditis. See, when there is a normal ECG complexes are going on, and here you can see an abnormal ECG complex where there is a focus of myocarditis produced an electrical impulse, and this is wide, bizarre, abnormal sinus complex is known as this BPC. One BPC in one is used to, and if it is not being repeated, but BPC itself is said to be dangerous and it has to be investigated. BPCs are generally seen in septicemia, toxemia, infections, fever, etc. All those conditions. See, this is another VPC. You can see there's VPC here. This is another VPC. See, this is a ventricular bigamy. That means there is a normal sinus complex. After that, there is a VPC. After that, there is a normal sinus complex. Again, next is VPC. Next is a normal sinus complex. So this alternating VPC is known as a ventricular bigamy. It's very serious. This has to be investigated. This is R coming overlapping the T. R on T VPC. This is another VPC. Again, this is dangerous. This has to be investigated in kidney failures, etc. Sometimes, after some normal sinus complexes, there will be a long pause, and after that, immediately an escape rhythm may come, and or immediately it renders or gains beat, and then there will be a tachycardia, and then there is a pause with the bradycardia. So this is known as a bradycardia tachycardia syndrome with a pause. This is otherwise known as a sick sinus syndrome. This is very commonly seen in pugs. Pug. Sometimes people may complain that the pug was normal. Suddenly it went down. It became unconscious for 5 to 10 seconds. Then it regained its consciousness. So this type of symptom is known as a sick sinus syndrome. It's very common in pugs. We have to see ventricular tachycardia. Sometimes there is no normal sinus complex at all. You can see continuous VPCs only. If the continuous VPCs are there, it is known as ventricular tachycardia. This can be very in the reverse. Either it is better you give 2 milligram per kg IV lidocaine can be reversed. See this VT in a dog. You can see this. In this VT, you can see it's a normal sinus complex here. You can see a VPC here. After that, normal sinus complexes. And then after that, you can see the VT, the ventricular tachycardia. Here also the same. Atrial fibrillation. Uncontrolled polarization and contraction of the atrial wall. That is atrial fibrillation. That can occur in acute kidney injuries, then hyperkalemia, then electric shock, etc. So this is very dangerous, and this is due to uncontrolled, or we cannot predict which area is being polarized. So such an uncontrolled atrial convulsions occur, that is atrial fibrillation. The ECG looks like, see, this is a normal ECG, here is a normal ECG, and in atrial fibrillation, it will look like in between two R waves, you can see the fibrillation waves. Those are the F waves or the fibrillation waves. In fibrillation waves, there won't be any P wave at all. You cannot see any P wave. Only fibrillation waves in between two R waves. This has to be investigated. See, this is a normal ECG, and here you can see the atrial fibrillation. You cannot see any P wave here. And abnormal waves in between are two sinus complexes. So the baseline will be abnormal. Ventricular fibrillation is again extremely dangerous because just before cardiac arrest, ventricular fibrillation occurs. And ventricular fibrillation, again, just like atrial fibrillation, it occurs as uncontrolled contraction and relaxation, uncontrolled contraction of the ventricular wall. Ventricular wall is so thick than the atrial wall, and so it is obviously seen over the chest wall like can of worms on the chest wall. So it occurs lightning stroke, in electric shock, electrocution, etc. So this is just before cardiac arrest. And now in this you can see a normal heart rhythm, and here you can see atrial fibrillation, here you can see the ventricular fibrillation. Here you can see the atrial fibrillation with the fibrillation waves, and ventricular fibrillation you can see the ECG pattern. See, ECG pattern look like this in VF, in ventricular fibrillation. The patient will immediately die if defibrillation is not done. Immediate defibrillation is needed in this case. This is ventricular fibrillation, where there is atrial standstill means there is no P wave. P wave is absent, and generally atrial standstill in our veterinary or paternal medicine, atrial standstill or absence of P wave is generally seen in hyperkalemia. Hyperkalemia occurs especially during kidney injuries, kidney failure, renal failures. So whenever there is atrial standstill or absence of P waves, we have to investigate the functions of the kidney. Kidney function test has to be done. See, this is again atrial standstill where you cannot see a P wave. All the Q wave, R wave, S wave, T wave, everything are there, but no P wave is present. Then, when there is a conduction block, AV block, when there is an AV block means from the SI node, the impulses are coming, the electrical impulses are coming to the AV block, AV node, and then there is a delay, more delay. Actually, normally there is a slight delay, we tell it as PR interval. If there is more delay, the PR interval increases. So, while it is passing through the junctional node, that is AV node, if there is a block or disastrous condition or a inflammation or any destruction of the AV node, pathological condition of the AV node, there will be delay in conduction of the impulses. Or sometimes the impulses may not be conducted distally towards apex. So it stops there with the AV node. That is also happening. So in first degree AV block, you can see a slight delay in the PR interval due to slow passing of the impulse. The second degree AV block, some of the waves alternatively will not be passing through the AV node, but the next wave will be passing through the AV node, producing the complete sinus complex. So intermittently you can see the P wave. Here is the P wave is there, the P wave is there, here the P wave is there. So that is second degree AV block. In third degree AV block, the sinus complex will be wide and bizarre, abnormal, but in between you can see more than one P waves. That is a third degree AV block. Here is the first degree AV block. You can see the increased PR interval. That is, here it is 0.24 seconds. Yes, long PR interval, that is first degree AV block. Coming to second degree AV block, you can see a normal sinus complex. After that, individual P. There is no QRS complex after the P. In P only, then coming the PQRST complex. Then again a P only. Then again a PQRST complex. Then a P only. So intermittently there is ventricular standstill. That is a QRST complex is absent. Only P wave is present. There is second degree AV block. The same thing it is here. And third degree AV block means you can see a sinus complex which is abnormal here with a very peak or T wave, and after that you can see P waves, lot of P waves here, and after that a sinus complex, then again lot of P waves here, then again a sinus complex. The same thing can be seen here. The abnormal EPC, abnormal sinus complex can be seen here. Again, after that the three P waves, and after that a sinus complex. Then you can see three P waves here. Again sinus complex. Again four P waves here. So all these things. This is third degree AV block. Whenever you get first degree or second degree AV block, somehow it is manageable. We have to go through vital organ function disorders, and we have to correct the function disorders. Sometimes the patient may escape. And third degree AV block, there is no chance of escape. Or veterinary patients, definitely they will die. Ventricular standstill, it is again like the third degree AV block. You can see the sinus complex, normal sinuses complex here. After that, the P wave here, and after that, sinus complex. This is ventricular standstill. Ventricular standstill is almost like the third degree AV block. Then ventricular flutters. There is no clear-cut contraction or sinus complexes. It is also again just like ventricular fibrillation. It is so dangerous. Flutters of the and abnormalities of the P wave. And I already said that the amplitude of the P wave denotes the right atrium, and increase in the width of the P wave denotes the left atrium. So when there is increase in the amplitude, we can say there is the enlargement of the right atrium. So if there is enlargement of the right atrium, it is attributed to the pulmonary chambers, the lungs, the pulmonary hypertension, etc. And so, since it is attributed to the lungs and the pulmonary system, we call it as, when there is increased amplitude of the P wave, we call it as a P pulmonale. And when there is increased width of the P wave, it is mostly attributed to the left side. It is left atrial enlargement. It is attributed to the damage in the mitral valve. And so, we call it as the increased width of the P wave is called as P mitral. So P pulmonale and P mitral are two technical terms which are very commonly used. Here you can see a normal P wave. Let us say L2 only. Don't take V1. So normal P wave, right atrial enlargement. You see the increased amplitude, left atrial enlargement, increased amplitude as well as the width. So increase in the width here, left atrial enlargement, increase RA, right atrial enlargement, plus the left by atrial enlargement. You can see the increased amplitude as well as the width is an abnormal one. See the difference between this wave and this P wave. This is a P mitral where there is increased width of the P wave. You can see a notching of the P wave also. This clearly indicates that is a mitral valve insufficiency. P pulmonale is always associated with the pulmonary pathologies. You can see the increased amplitude of the P wave is P pulmonale. Tall R waves can be due to increase in the size of the right ventricle as well as the left ventricle, especially the right ventricle. Electrical alterance, and when there is loose electrodes or cardiac tamponade or severe pericardial effusion or hemopericardium, we can see different R wave amplitudes. See the difference in R wave. See this R wave amplitude. 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 So it is different. This is known as electrical alterance. Generally happens in loose electrodes. You have to tighten it. If we tighten it again, it happens means there could be a pulmonary this pericardial effusion or pericardial tamponade or hemopericardium, etc. We have to rule it out. Then we have to say something about the J wave or the Osborne wave or the camel's hump. The J wave. This is a J point actually in between the S wave and the ST baseline. It's a J point. When the J point is there, see J point is seen here. Here, these are all normal J points. Can be elevated, can be depressed, and sometimes the J wave itself can form. That is known as a J wave or the Osborne wave or a camel's hum. The J wave, if J wave is found in any animal, it is seen in hypothermia, hypercalcemia, brain injuries, and acute fevers. Then sometimes most of the ECG patterns you can see the U wave. U wave. If U wave is so prominent, it indicates hypokalemia. So mostly it's a small U wave can be found, and U wave is U wave is generally seen in between. And don't get confused that it is a second degree heavy block. No. It's a very shallow one only. Very small one, a shallow one. And if at all it is like a very large one, it can be hypokalemia. It picks up in hypokalemia. See, this is a hypokalemia, and the potassium level was just 2 milliequivalent per kg per ml of blood per 100 ml. So you can see the elevated U wave. So that is a U wave. Again, in pericardial diseases, along with the normal P will be there, normal QRS complexes will be there, but peak R waves will be there, peak T waves will be there, peak T waves. That's a clear ECG pattern in pericardial disease. And R wave notching, sometimes we can say as Wolff Parkinson White syndrome, can be happening in some left ventricular hypertrophy. Left ventricular hypertrophy, R wave notching can also happen. In hyperkalemia, there will be tended or peak T waves. Along with that, there may be absence of P waves. Absence of P waves with tended or peak T waves, that is hyperkalemia. That means atrial standstill occurs. See, now we can see what happens. See, it is normal 5 millimoles per liter is the normal one. You can see it. See this normal. When it becomes 6 millimoles per liter, it is there. We can see the loss of P waves here. The loss of P waves or slight depression of the P waves here, or tended R waves, slightly tending of the R waves. When it becomes 7 millimoles per liter, too much of tending of the R wave, peak T waves. Along with that, there is shallow P waves. When it becomes 8, there is complete absence of P waves with abnormal wide QRS complex and tended T waves. And when it becomes above 8, there is a sinus wave pattern, ventricular fibrillation, etc. can occur, then cardiac arrest. In hypokalemia, as we have seen, there is a prominent U wave. This is a normokalemic animal where there is a shallow U wave, but in the hypokalemia, you can see a prominent U wave. U wave should always be differentiated from second degree heart block. Then in hypokalemia, in hypocalcemia, in hypercalcemia, there will be short QT interval, and hypocalcemia, there will be long QT interval. That is a typical ECG pattern. In this hypocalcemia and hypercalcemia, thing can be seen, I already mentioned it. Then hypothyroidism. In hypothyroidism, let us take 2. In hypothyroidism, you can see extended or long QT interval, hypothyroidism. See, this is so typical to hypothyroidism. When the patient is already having all the symptoms of hypothyroidism, we can go for this ECG and take the QT interval will be long. We can say confirm it is almost hypothyroidism. Otherwise, you can go for T4 TSH evaluation. Then again, 50 cycle interference. Sometimes we are using mobile phones, we're keeping the mobile phone near the ECG machine that can interfere, causing 50-cycle interference. We can put on the filter. We can put the filter on so that it will be rectified. That is 50-cycle interference. Sometimes, if you take the ECG in the cat, purring is normal. Grrr, grrr, that purring will be there. And due to this purring, and during that purring, you can see abnormal waves like this. Looks like atrial fibrillation, but these are normal. It's known as purring artifact. We cannot do anything against a purring artifact. We have to think about. You see, this is just to make you give you a general idea of how cardiology is and how ECG is. So, my dear friends, we are coming to the last slides. Now, the respiratory artifact. These are animal may be gasping too much because we are forcefully making the animal lying down. They may be gasping too much, and you can see the respiratory artifact. So, this is actually the baseline, and here in respiratory artifact, we can see this is a respiratory artifact. These are not the waves. This is the wave, this is sinus complex, this is the everything. But otherwise, we cannot say that it is a respiratory artifact only. And my dear friends, by this, I am completing my cardiology webinar, and I hope that you got a good idea, a basic idea of the general canine and feline cardiology. And I hope that you can develop by this piece. Because in this 1 hour webinar or 1.5 hours webinar, I can do only this much. If I'm going to elaborate all these things, it may take some hours together. So let us see. If I'm getting time, definitely I can spend 5 or 6 hours with you for teaching you complete cardiology. So thank you very much for listening to me. Thank you very much. Namaste. Bharat Mata Ki Jai. Long live our motherland. Thank you very much.